Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring tech legend Jay Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Marie Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. The NeuroNoodle podcast is supported by listeners and businesses just like you.
Hello, hello.
Hello, Jay Gunkelman. Resistance is futile. I love it.
It's a short.
That's amazing. How's California, Jay?
Well, it's been smoky for quite a bit, but we've got some nice, clean, fresh air out. So I've got the house wide open, nice 54-degree breeze going through.
The west wind.
Having grown up in Fargo, that cold weather feels like home, you know.
Absolutely. So. Dr. Hedaya, welcome to the show.
Thank you. Very nice to meet you.
Pleasure.
Jay, I don't know you, but I saw you honored at I forget which meeting 4 or 5 years ago. So it's a pleasure to meet you.
I usually try to dodge the honors best I can, but they're throwing them at me left and right. You can't dodge this stuff, you know.
Yeah, well, it's a good problem. You know? That means you did good work. Yeah?
Dr. Hedaya, we're just a bunch of friends getting together talking about well-being. You've been practicing since '79, I believe.
Yeah.
I checked out a couple of your YouTubes. I saw something on depression. You started that in 1980, I think. Could you give us a little background? Dr. Marie Swingle will be popping in, and we're just having a little cocktail party. People are just showing up and pay no attention. Dr. Hedaya, welcome to the show. Please tell us more about yourself.
Wow, thank you very much. It's a pleasure to be here. I love the guitars. I'm a guitar player myself, and we could talk about that afterwards, I think.
Okay. You're probably good.
Yeah. So, I'm it's trained as a psychiatrist at Georgetown National Institute of Mental Health, and essentially my nature is to do the highest quality work I can do. It's just my nature. I'm just built this way, and I seek the truth wherever that takes me, and I can do that particularly well in my profession. It's a little tougher in your personal life, but I'm making headway. So, I would say I started out at Georgetown and I was learning, all the basic stuff in the early 80s. And, psychopharmacology. I was certified as a psychopharmacologist, teaching cognitive behavioral therapy at Georgetown. And then eventually, through really some things in my family, found that I couldn't really rely on the medical establishment to look at the medical side of neuropsychiatric problems. And I started to have to learn some endocrinology, et cetera. And one thing led to another. And by the end of the 90s, I ended up doing functional medicine. So I got trained early on with Jeff Bland, and I was doing that. I wrote a book and was blown away when I really applied the functional medicine model consistently to people with treatment-resistant depression. After about 3 years of treating people just really with that and very little change in the pharmacology, that everyone was getting better. And not only was their depression getting better, but their diabetes, their osteoporosis, MS lesions disappeared. I was like, maybe I'm lying to myself. So I hired a statistician, and I had the statistician go through all the data of the previous patients over the course of about 2.5 years that I treated with this model. And I wasn't lying to myself. It was, I think, 23 or 24 patients with treatment-resistant depression, and they were all normalized, meaning a Beck depression inventory under 10. Starting out in the mild severe range, they all were under 10 by 10 months. And I only made one change in medication. In one patient who was suicidal, who I put on lithium. That was it. And that was it. There's no turning back. Then, just to finish it, I retired very briefly in 2014, but couldn't stay away. I really love what I do. And then basically came to, fortunately, realize that I could help the brain with light therapy, lasers, And I didn't know like where should I apply the light. So I started to look at QEEGs, and that took me a while. As Jay knows, it's not a simple thing. It took me a few years to get up and running with that. And then with QEEG guided laser therapy and neurofeedback and hyperbaric oxygen, ketamine assisted therapy, we can actually now work inside the brain. And what we found is that functional medicine is very helpful in many, many ways, but it actually doesn't fully normalize the brain for most people. We need to do the in-brain treatments, which I call a high lane cap.
What would be your definition of functional medicine, doctor?
The easy definition is basically root cause medicine. So you look for the root causes of things. You don't apply band-aids. You don't, you could use medications or things like that, but you want to get to the root causes of things. And it's not a linear medicine. It's not A causes B. It's really systems medicine. So the analogy that I use with patients, I say, look, if you came to me with your grandfather's stopwatch and, you wanted to use it, wear it at the wedding and you want it to work, and I'm a jeweler. You bring it to me. I open the stopwatch, and I look. There's 20 flywheels, and 6 of them are broken. And I say, "You want it to work Saturday night? I could fix all 6." You say, "No, no, no. Just fix one at a time." Okay, well, it's not going to work. Maybe the second hand will move when you've fixed 5 of them, but that's it. You have to fix all 6 because they're interconnected and interdigitated. And it's the same with the body. The body systems all interact with each other. And so you have to be thinking in systems medicine.
You mean we're not disembodied brains? Oh my God.
Well,
My whole career is lost,
I always joke, I say the brain is actually connected to the body by this thing called the neck. And but they didn't have a lecture on that in medical school.
Well, and you refer to yourself as a neuropsychiatrist, and that's a bold statement because in psychiatry, if you're going to become an electroencephalographer, they kind of force you to go back through neurology residency to get there, and that you can't take high level EEG courses as a psychiatrist without basically going back through neurology as some sort of a hazing, um, which is bizarre. I mean, the plaque on the wall when you got your board said neurology and psychiatry. So why are you the tail and them the dog?
Yeah.
Uh, so that it's really unfortunate because I know a lot of psychiatrists that are interested in the EEG, but not interested in the rigmarole to go all the way back through, as I say, a hazing, basically, to take away all the thoughts of psychiatry and only look at it like it could have epilepsy or some encephalopathy, which is traditional EEG's kind of bizarre. If you're not specific, you're not real. Uh, and they've thrown away all of the interesting psychiatric correlations, and which is a shame because, as you know, the EEG is the organ of consciousness, and it reflects our function so precisely that for the last over a decade, I've been doing my lectures without knowing anything but the age and looking at the EEG and processing through it a little bit with some spectra, but no norms, just looking at the EEG and telling you what the neuropsychiatric presentation of the client is.
Right.
So that you can reverse engineer it. I mean, nobody reads an EEG that way. You either know the patient or you get the referral with a history, but you can look at it in that depth. But neurology doesn't look at it in that depth.
Right.
It's a shame. In psychiatry, you use anticonvulsants not to stop seizures because you're not, you would refer that to a neurologist if they're having seizures, but you use it as a stabilizing agent. And we found a very nice study, 76 patients that had epileptiform content. They were psychiatric patients of a wide variety of DSM categories, but those are bunk anyway. So we just lump them all together because the DSM's a mirage. So those 76 patients that had epileptiform content got an anticonvulsant for an empirical trial. 85% of them got better. Traditional neurology would have denied that care because they weren't having seizures. Again, the bizarre twist around. We don't treat the EEG, we treat the patient. Well, what the hell's the EEG for then? But you see, you've made it through the hazing in a way that you are a neuropsychiatrist and well respected for the cross-disciplinary depth of knowledge. I mean, you see the interviews of you doing grand rounds at uh, uh, major institutions and your professorship. So you've been through all of that. I myself just skipped all that. I went to a laboratory in 1972, and I've just been playing with data since. I'm a tech. I never got anything but a BS degree, which they gave me 2 years after I left, uh, because the other students were wondering if I didn't need a degree, why would they have to get one? So they sent me one to quiet their students down. So we went totally different routes, but we've, I think, come to the same point where we see the brain and body as a system, a rather complex system of systems, but you can't separate them. And we've got a kind of a hot spot we're looking at as a finding in the EEG we're going to focus on at this year's Suisun Summit meeting, the Insula. And the Insula is able to make some rather amazing psychiatric presentations, from dissociation to sympathetic parasympathetic balance to interoception, spasms in the intestinal tract. It's associated with Crohn's disease. So the we really are going to show a case series where the insula in the EEG was identified, treated with neurofeedback, and the gastroenterology people were surprised when the GI system normalized. So the top down for the gut, we know the bottom up happens, but the top down is also important.
There's just a study, as you talk about top down, that I read on chronic fatigue and myalgic encephalitis, chronic fatigue syndrome, fibromyalgia, has different names for that. And they basically looked at the body of people with CFS, chronic fatigue fibromyalgia, and they looked at their muscles, they looked at the cardiovascular system, they looked at the grip strength, they looked at like 8 or 9 different parameters to see what was different in their body. And nothing was different in their body, but the right parietal area it wasn't QEEG, but it was on some other type of imaging, was malfunctioning, the right parietal area. So we have actually, it so happened at that time when I read this about 6 weeks ago, that I already had 3 patients set up. Based on their QEEG, I was targeting the right parietal area with the laser, and to reduce pain and energy and improve energy, and it actually works. So there's just like phantom limb pain, right? Phantom limb pain. If your audience knows, you lost your leg, and now your right leg and your right toe is itching, tickling you or whatever, but you don't have a right toe. Well, it's coming from the brain, and in some cases, we don't know how many, but some percentage of cases with fibromyalgia and CFS, that's coming from the brain, the top down, just like you talk about. It's a major effect, major effect. And
Yeah.
and
A dear friend of mine who's a neurosurgeon, Dirk de Ritter, uh, got a machine learning algorithm to identify thalamocortical dysrhythmia, where the thalamocortical column for the phantom limb lost the input, so the alpha in that column slows down into the theta frequency range and cross couples with 40 hertz, which
Mhm.
surrounds it. The lateral inhibition has been turned off by the loss of the input,
Mhm.
and that gamma surrounds it. It's not normal gamma that chirps on and off. It's permanently on, and that's linearly related to the pain, or if it's in the auditory area,
Tinnitus.
the phantom sound of tinnitus.
Right.
And if you have tremors or Parkinson's rigidity, it's the premotor area.
Right.
And if you have uh, the reward deficiency is the anterior cingulate. And
Right.
so the same failure with a different neural network ends up being identifiable with a machine learning algorithm. Published it in Nature a few years ago.
Oh, I
Uh,
love that paper. I would love that paper. That's
oh
fast.
yeah, yeah. I'll be happy to send it to you.
Oh, wow.
But the it's a it was also interesting to see a TMS protocol
Mhm.
that targeted the thalamocortical dysrhythmia
Mhm.
and also provided a dissociative of ketamine.
Mhm.
Or they have a whole list of dissociatives, MDMA. You know the list.
Right.
So what they basically end up doing is getting past the DSM. Right
Mhm.
now, you have to have depression or OCD. They're doing a little PTSD possibly. They'll add on new DSM categories as they go, but
Mhm.
this gets past all of that, and they just basically look at the brain and target it based on the EEG having a dysrhythmia,
Mhm.
and
That's
use the
fascinating.
TMS on that.
That's fascinating. That is really fascinating.
Well, they patented it, but the patents are no good. 75% of all patents fail on challenge, and these kind of patents are just ripe for the plucking. But it points to that as an interesting approach, and other people should realize that these kind of patents are done for business reasons, and they don't really hold up. So,
Mhm. Mhm.
yeah.
Jay, at the beginning, you said that all you needed to see was a person's age on the EEG.
Yeah, and
I didn't hear
I'm not
gender.
good at I'm not good enough with my own eyes to be able to see the gender differences in the EEG, but they're there. When I advised the Koreans when they were collecting their normative data set to separate male and female and to do two total database separate, which is 5 years instead of 2.5 years. It took a long time to get all the data together, but the differences are there. When we had a database and you had a couple people to compare, they kind of similar, but you can't really compare a large group with a couple people validly. You have to have similar population sizes for valid comparison. So now that they have the full database together, the dramatic difference between male and female is there. In females over 45, they light up with electric fast activity in a gamma range and fast beta. Males go kind of electrocerebral silent up there. And to average high fast activity and low fast activity together in one database of average, what do you have, a unique database?
Mhm.
So we really do need to have that separation. But my experience was enough to tell me we had to separate the data. I didn't know the depth of what we would find by any means. And
Mhm.
um, I'm glad it was actually a difference because I had to work twice as hard. That they
Does
could have
that,
come over.
Jay, does that difference disappear, do you know, after menopause?
No, it's from 45 years old on up. They end up having fast activity in the EEG, and males, the fast activity drops about the same time.
Hmm.
During the developmental trajectory. males and females, there's components where the males and females are out of cycle on their developmental surges, and you see differences that are predictable during that rapid developmentals up to age 8 or 10, and after that things kind of stabilize as slight differences, but then 45 on up, again they become really quite a dramatic difference.
I mean, it's interesting because hormonally, we kind of move in the same direction. Men have, become more feminine in a sense, and women become more androgynous in a sense, right? And I would think that that the brain would it kind of come together, but you're saying they don't.
Not apparently. I think we get left in the dust. they they light up and we dim out.
You're burned out.
Um, but well, who knows what hormonal influences might be there? For those of you who have hormonal regulation, I have no pituitary, so I adjust my hormones however I want.
All right.
So
Yeah.
it, and it does give you some interesting insights to be able to manipulate your hormonal levels. If I have high testosterone and high growth hormone at the same time, you get a bulletproof sense. I used to think teenage kids that did stupid shit just were stupid kids, but I think that the bulletproof sense is a hormonal.
Oh, no question. No question.
Absolutely, uh, the man of steel. Go ahead and shoot.
Yeah, no
So,
question. There's no question
um,
about that.
yeah.
I,
Anyway,
I always say big bodies, small brains, but it's testosterone. That's a big part of why we see what we see in the newspapers.
yeah. Well, there's testosterone poisoning being suggested by a lot of the young women I see. But,
Right.
um, that testosterone is important for women as well, though. In severe depression in women, quite often testosterone, that if you test and it's low, testosterone provided ends up giving a mood lift. There's publications about that. Um,
We use a lot of hormones, estrogen very commonly perimenopausally, postmenopausally with bioidentical, obviously. And then, interestingly, you talk about hormones. I've seen on the QEEG significant improvements in people who have a mild adrenal insufficiency, hydrocortisone replacement bioidentical again. And we see actually a big improvement in the DTI on the neuro navigator. That's what I
yeah.
use. And
Well, I eat hydrocortisone morning and afternoon every day. No pituitary, you have to
you
end
have
up
to do
doing
that.
hormone
Yeah,
replacement and uh, you know steroids, the breakfast of champions.
That's
Uh,
right.
yeah.
Dr. Hedaya, welcome to 60 Minutes of Tangents. You're you were Teacher of the Year at Georgetown. I got a question for being a teacher. What I've heard on this show, because I'm Jay's an overglorified tech. I'm an overglorified video editor. What I've heard sitting here editing is that neurologists don't like to use the EEG reading because they don't believe that the teachings of the readings of the EEGs have been standardized. Do you have a thought on that?
Listen, it's just an example of idiocy. It's just an example of people being stuck in a paradigm. It's just an example of financial turf battles. It's not logical. There's no basis for what they say. In my training, I was afraid of an EEG. I mean, nobody taught me anything, and I did do rotations in neurology, by the way. And to get back to your point, Jay, I feel comfortable because I can now look at specific neural pathways, specific nuclei. I can measure their volume with neuroquant volumetrics. I can compare the QEEG data to the neuroquant or to the PET scan, and they correlate very well, not perfectly, because one is functional, one's structural, et cetera, but there's very good correlation. And we have actually shown that you can actually grow back parts of the brain. We've grown back parts of the basal ganglia. We've normalized the hippocampal function. The brain's extremely plastic, and just even in older
Yeah.
people. So I'm very comfortable saying that I do neuropsychiatry, and I think is much more accurate to what I do. And I think that the neurologists they're stuck in the mud. They're just stuck in the mud. That's it.
Yeah. Attitudinal sclerosis.
Yeah, and this is human nature, by the way. This is not just neurologists, and I think there's something I struggle with, because I try to get my message out as much as possible, but
Yeah.
people are rigid. And people like certainty, and people can't tolerate the anxiety of not knowing and change. So there's only, a small percentage of the population that are early adopters and open to looking for truth, not happiness, but truth. And that's a small percentage. And perhaps that's good for the stability of the society, et cetera, but it doesn't mean that what we're being taught is true. It doesn't
Yeah.
mean it, and it's not, so we crawl and advance slowly in the medical and other fields, not all fields, obviously, but
It must have been very terrifying to be a psychiatrist when the DSM-5 came out, and a couple weeks before that, they declared that it had no predictive validity and
you
was
know what?
fabulously reliable, but not at all valid. And
I have
and
no, I have
oh
no,
my God,
no. I have never had a moment of terror in psychiatry. Never, 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 because I'm just trying to figure it out. That's it.
yeah,
And when I went into practice, they told me they tried to terrify me, right? They said, "Oh, you can't go into private practice because Blue Cross Blue Shield only covers 2 visits a week now, instead of 4 visits. This is back in 1983. And I'm like, I'm just going to go out there and do the best I can do. If people want it, they'll want it. And if they don't want it, they won't want it. I'll do something else. That's it. And so I don't really worry about those things.
well, the academics that were doing research based on a DSM category, but no biomarkers or
Right.
neuromarkers or genetics or anything like that, had
Yeah.
all of their funding threatened. So there was a big institutional pushback
Uh,
towards the DSM, but it's basically being kind of abandoned for cause.
yeah, well, look,
Um,
the insurance companies like it. And
yeah,
that's really what's running
yeah,
healthcare, is the
yeah.
insurance companies,
Yeah,
right?
got to have the DSM for payables, but
Yeah, you need that, the ICD-10, you need all the codes. They keep them changing all the time so they can, whatever purposes
yeah,
that.
but all those systems are based on symptom. And if
Mhm.
you're a cardiologist and everybody that came in complaining of chest pain went in for an angioplasty, half of them had indigestion.
Right.
You've got to listen to the story, and that should tell you what to test, not how to treat.
Yeah.
So we're missing a step in psychology, psychiatry typically, and that link gets you to the pathophysiology, the underlying problem, and the core fix.
Mhm.
And if you fix the foundational problem, a lot of things get a lot better. As you say, the psychiatry got better, but their other bodily complaints end up improving as well.
You
When
know,
when systems work well, things flourish.
this is 2017 so I had come back into practice, and I was learning about the QEEG, and then when I was finally ready to do some laser, QEEG guided laser, my first patient was a woman who, and I published this, she had prosopagnosia, so trouble recognizing faces, which, by the way, I didn't know, even hadn't even heard of it at the time, right? And I was treating her for early dementia, very early, mild cognitive impairment. And she had a history of trauma, head injury, emotional trauma, head trauma, toxic exposures, et cetera. So we worked in functional medicine for 6 months, and she felt much better, but she was still having some trouble with her memory. It was a little tougher. And still than it should be, and some trouble finding words, and but significantly better, right? Exercising, doing great, feeling great, energy was good. So the first treatment, the laser, I decided where to target, and took 5 minutes, and then she came into my office to make an appointment for the next treatment. And she says, I have this, I actually have her on recording. She was so impressed. She says, she had an accent. She goes, "Oh my God, I can remember the face of the person I worked with this morning. Oh my God, and the dimple on his face, and his wife. Oh my God." It turned out that she had been, the facial blindness had caused so many problems that she had developed systems to actually, take pictures and write down exactly what it was. And so she would arrive at a place she had been the day before, and she couldn't remember whether she ever met this person before or not. So she had pictures and everything. That was cured with one laser treatment. And it's because I believe there were the cells in certain area were in a liminal state, and we just kind of jump started them, and it working. Now, it was quite astounding because it broke. This shouldn't happen, right? This shouldn't happen. Like, I couldn't fit this into any paradigm. I came home, I'll never remember, with my wife. I didn't know what to do. I'm holding my head. I'm like, I don't get it. I don't get it. I don't understand. This is crazy. It's like, it was too big, too big. But there's so much we can do now. So much, and I cannot imagine practicing without the QEG anymore. I think it's absolutely correct. I'm nowhere near where you are, Jay. I'm like an infant compared with you, but I find it indispensable.
Yeah, I don't I don't expect other people to have the experience I have because I'm weird and I had a odd course to get where I am through the busiest lab in the world. And all the people that were associated with that were older than me, obviously, and they've all passed. So anybody that has seen over 500,000, and I quit counting a long time ago, so it's over there, up above there somewhere. I mean, nobody believes that 500,000. You do the math. We did over 100 a day, and just do the math at 100 a
Right,
day, and
right.
20 plus years of that, and the numbers just go crazy. So,
Right. It's amazing. Just
Here,
amazing.
let me give you a famous quote. Show me more data. How much more data and studies do we need, doctor, for people to take this more seriously and get us organized where people can take advantage of this and insurance will pay for it?
It's not a matter of data, really. I mean, it's a matter of, it's probably, if you can show the insurance companies that there's a cost benefit, in their favor, then they'll adopt it. Somebody has to do that. It's
yeah.
not a matter of data, if you have that data, that's good. That would be good.
So in Washington State, a client of mine, neuropsychologist, started to do QEEGs, and he tried to get insurance to cover it for an autistic kid, and they just denied it. And the parents up there had fought for parity, so they had to actually spend up to $500,000 a year treating the autistic kids in the state, but they had to go get diagnosed at a center of excellence. And my client was one of those centers of excellence, but he couldn't get this covered. And the case manager spent money on other treatments for a year, wasting hundreds of thousands of dollars with no effect. And he came back and said, please, can I get this, covered? And she said, out of frustration, sure, go ahead. So he did the EEG, QEEG. We found epileptiform content, and 60% of the autism population have it.
Wow.
They got an empirical trial and a convulsant approved, and the kid gets better, comes off the autism spectrum entirely.
Right.
So after that, when he calls the case manager for permission to do the test, you got to get an authorization. And it still doesn't mean they're going to pay, but you get authorization ahead of time, and he gets it authorized every time now because he saved them $500,000 a year by getting the kid off that diagnostic category entirely with an effective treatment.
Mhm.
So anyway, uh, I think that the efficacy stuff is slowly coming together.
Mhm.
It wasn't all that many years ago when I was president of ISNR, and I was hearing people claim, can you treat this? And somebody said, oh, yes, we can treat that. And I was going, geez, based on what? I mean, what are you making that claim based on? Where's the study, or what's your experience? I mean, where are you coming from with that claim?
Mhm.
And Don Moss was president of AAPB. I was president of ISNR, and the two societies got together to co-publish, with two publishers publishing at the same time the position paper on what kind of research designs you had to have to make what kind of claim.
Mhm.
And like the Chambliss criteria for an APA, except that had one little baby step up, possibly efficacious, then probably, then efficacious, then specific. So the hierarchy had to give us kind of a little leg up because our field is kind of unfunded. So
Mhm.
a lot of the studies are small and with minimal design. Yeah,
Mhm.
but over time, because you can see what you need to have in order to make the claim, people have done the work, and the publication of the white papers with AAPB on an ongoing basis, updating what what applications have evidence, and which ones are still at what level. And so we're getting the efficacy out there in publications, but it's if today it was being taught in medical school, it would still take almost a decade to penetrate clinical practice.
Right.
As you know, it's a corporate practice out there,
Oh, yeah.
and if you go in as a junior partner, you can't do what you want. There's a flow chart of decisions that you have to follow, and you can't really bring in something new. But a decade later, you're a senior partner and you can do what you want. So, if it came out of medical school with full training right now, it would still take about a decade to penetrate practice.
At least, because I was very involved in COVID for takes COVID, and I was had my niece actually was in Cornell for 6 months. She was one of the early cases on respirator for 6 months, and I was dealing with the ICU every day for 15, 20 minutes, monitoring what they were doing, and their inability to think outside of the algorithm. Now, to give them credit, it was a very stressful time. They were working long
Yeah,
hours. It was very difficult. There were people working in ways that they didn't really weren't trained to do, and they were given algorithms from higher ups, and that was it. But I uh, I had to fight with them to give my niece actually was on the death's door 4 times, and I had to really really fight with them and present evidence to get them to give her some steroids, which they did against their will. um, and one of the doctors hung up on me and said, I will not give her any steroids. I said, are you aware of the paper by Hertz, et cetera, 3,500 people in ARDS? I will not give her steroids. Click. But she did, and she recovered. And so there's that whole mindset. It's not about thinking in medicine anymore, and it's about following an
yeah,
algorithm. And the algorithm, in theory, is evidence-based, but the evidence-based is obviously highly flawed, and there's not any thinking going on. And
yeah,
I always say, if the people who are doctors now were on Apollo 13, it wouldn't have come back because they don't know how to think. In Apollo 13, they solved their problem. So you could teach us in medical school, and we should be teaching it in medical school. 100% we should be teaching it, but then the upper echelons will push it out. It'll take 20, 30, 40 years, but even functional medicine is seeping in through the cracks. People
yeah,
know more and more about functional medicine, and there are hundreds if not thousands of doctors being trained you know every year in functional medicine, and it's going to happen. because this is where the reality is. And then AI is going to make a big difference here
Yeah.
as well, because doctors are going to become less, they'll be around, but they'll become less important. And if AI is good, it's going to discover these correlations, which are inarguable, right? So
Yeah.
I think we'll probably see a big advance there.
Yeah, it appears to be reshuffling the DSM categories at this point. That some pretty much every category of the DSM has multiplied out in some fashion, and finer and finer gradations of it. But OCD's kind of hung in there as a single thing,
Mm-hmm.
and we know if you have OCD where the problem is.
Mm-hmm.
But it actually has 3 separate EEG features that predict different medication responses.
Mm-hmm.
So it's going to take the integration of EEG QEEG into psychiatry, and without the neurology dumb down happening, in order to end up really understanding how to treat properly, because the anterior alpha, if it's below 10 hertz and you have anterior cingulate alpha, 85% positive response to an SSRI. What study shows 85% positive response to an SSRI? Maybe 50, maybe
Not here.
55, but not 85. So this is a lock and key exact match. If you have slow content in the theta band up there, you don't respond. They may leave you on the med, but you don't respond. But you didn't have a bad response. It's just, you didn't respond. If you have beta, on the other hand, and they give you an SSRI, you melt down,
Right.
and you've got to have a whole different medical approach. So, and you can predict it before they give it. So it's kind of a shame that it's not part of that decision tree already, because it's the biomarkers are really quite distinct.
So what we do with OCD is very interesting. And I wasn't aware of what you were just talking about. That's real. That's another paper you could send me. I would love to see that also. I was scribbling it down as you were talking. But so what we look at with OCD, first of all, from the functional medicine perspective, is we look at inflammation, right? Because when you have inflammatory stimuli, wherever it's coming from, could be from the gut, it could be from mold, it could be Lyme disease, whatever, tick-borne infections, whatever it is, mycoplasma. What happens is the tryptophan, tryptophan should be converted into 5-HTP, for 5-HTP to serotonin, serotonin melatonin. So there's an enzyme called 2,3-indole dioxygenase, which gets activated by inflammation, and it shunts the tryptophan down this glutamate kynurenic acid, quinolinic acid pathway, and you have more glutamate, which the
hyperexcitability at that point.
Lower GABA, right? Lower serotonin, and then you have actually excessive zinc utilization by the immune system. So the serotonin signaling gets really messed up. So one layer of OCD treatment is looking for inflammation and infection. Another layer is genetics, because we see a lot of these people have trouble actually genetically converting the tryptophan into 5-HTP. And so you could just bypass all of this, but with 5-HTP.
Yeah, that inflammatory presentation would undoubtedly be the beta spindle, which is enhanced by the glutamate.
That makes sense. That makes sense. And so
glutamate modulators end up being a good way to treat it, but getting rid of the problem is a good thing as well.
That's what we do. And then here's the most interesting thing recently in the last couple of years is this ketamine assisted psychotherapy that we do, and we've done pre-post QEEGs to see how's it affecting the brain. We're actually crunching the data right now on 24 cases. It's not a big sample, but we're crunching the data, and it looks like there's a big effect in theta. And but we have to drill down more. But the interesting thing is this: the OCD clearly improves with the ketamine. And then what happens is people, I've been talking to people, this gets to the psychological realm of it, is I've been talking to people about, taking that information, the OCD. So you have an intrusive thought, let's say, your partner, you just imagine your partner being thrown off a building or something like that. And you go, oh my God, what am I thinking? This is horrible. Well, that is, I think that is the content of it, not the process of why you have it, but the content of that is useful because it's pointing you to something that you're feeling about the relationship. Now it's like a poor language. It's a primitive language that your reptilian or your limbic brain is conveying to you, almost like a dream language, but it's conveying something to you in a language you can decode and learn from and actually address. So OCD, I think, is present across cultures in 1% of the population. It's like you say, this is real. This is indistinct. This is a real deal problem. And when you attack it on multiple layers, even with neurofeedback, and even the laser will go into the anterior cingulate. I think it's quite treatable.
The TMS approach basically does stimulation. But if you look and you find a beta pattern,
You don't want to
stimulation is not the thing you needed to
right,
do.
right.
And you could do 1 hertz and turn off the beta, but they go in with the assumption that you need to stimulate. And they try to induce the OCD as they kick in the stimulation. The video from the company basically shows an over-the-shoulder shot with the shoes of the woman, and they've got her purse. She's got something about her purse and cleanliness, and they've got it on the table. And they say, we're going to move your purse to the chair. And they move it to the chair, and the feet make a little twitch, but not so bad. And then they say, I'm putting this piece of paper on the floor. I'm going to move it to the floor. And her feet she's squirming in the chair. They've got her OCD totally triggered, and that's when they kick in the stimulation. You have to activate the network that's the problem, and then you hit it. And for those, they've either got the alpha or the theta pattern, and that stimulation works.
Not
But
for the
if you've
beta.
got the beta pattern, and
Works.
you can tell ahead of time if you look. And only recently is EEG and TMS a big topic at the Clinical TMS Society. I know I was on their planning committee for 5 years. So, and at the end of that, I actually did a workshop on thalamocortical dysrhythmia and targeting in TMS.
Wow.
So,
Wow, that's fascinating. Really fascinating. So 1 hertz, that's interesting. So 1 hertz slows down beta. I could use 1 hertz laser actually in the anterior cingulate if I have someone with high beta in the anterior cingulate.
yeah.
And that would be an approach. That's very
Yeah, it's the low frequency can kind of do the dropping the cortical arousal, and the higher frequencies have to be at or above the alpha frequencies, but they activate. And now they do theta burst, which is very high frequency and short bursts done in a pattern like a theta pattern. They're trying to get closer to the actual brain's electrical signaling. The brain has spike trains and so forth, and the very high frequencies done in a theta pattern. High frequencies nested in theta are kind of how the frontal lobe has a lot of the EEG anyway. So
I'd
anyway,
be curious about your opinion. Uh, I maybe because I'm used to it, I kind of like the idea of the photobiomodulation more than I like the TMS because I feel like the TMS is basically a
yeah,
form of ECT. It's a form of disruption, whereas the laser is it's
yeah,
pulsating, but it's also energy, delivery of
yeah,
energy and blood flow, and activation of growth factors. But let's say just energy is the primary mechanism,
yeah,
and you're delivering energy, so cells, they kind of know what to do, or you can guide
yeah.
them to do what to do. What are your
And
thoughts?
In TMS, the pulse can force you to move your fingers or your toes.
Right,
They can create an action potential
right.
and force function. Photobiomodulation can potentiate function,
Mhm,
but
mhm.
it can't force it.
Right.
And I think it's a gentler approach,
Mhm.
um, and it has good efficacy. Uh, and goodness knows, photobiomodulation doesn't have a $250,000 machine associated with it.
Right.
So,
Yeah. Right.
um, if on a cost benefit basis, you could do a hell of a lot of photobiomodulation
Right.
for the price of one session of TMS.
Right.
So,
Yeah.
Doctor, we're getting towards the end of the show, and I want to send some clients your way. Let's talk about your brain recovery center. What's the if you could say the top three symptoms of the people that come in? Look, it's not one thing that causes it. It's not going to be one thing that corrects it. But what do you see coming in that you can help with? Where are you? Do you do anything remote? Let's plug your business a little bit.
Well, so very, hard to say what are the top three things because if you go to my website, you'll see there's like 25, 30 things, whatever, because we're dealing with underlying processes, not with diagnostic categories, right? Right now we're focusing on aphasia, and mild cognitive impairment, dementia, depression, chronic fatigue, fibromyalgia, and then even long COVID now. There's a lot of that coming through. So, those are the things, but we're doing PTSD. I mean, so there's a lot of things. Now, we were in Maryland. I was in Maryland for 40 years, just relocated about 2 years ago to New Jersey, the shore. It's beautiful. Love it here. I feel really blessed to be here. And so people have to come for the initial evaluation in person. You look, my evaluation is about 4 hours, 4.5 hours.
yeah.
I'm with the patient myself. We do a lot of testing, get baseline data. I'm very data oriented, and then we see what's going on based on the symptoms, based on the labs, based on et cetera. And then we treat what we have to treat in a sequential manner. And then people can do Zoom appointments if they're out. We have people around the country really who they do Zoom, and they'll come in maybe once a year or something like that for in-person appointment, or sometimes they come in more. I have some people who actually come here for a few months for treatment. Um, so it depends on the person.
Well, you okay, let's depends on the person. Let's just say Bruce Willis just happened to trip over this podcast and let's talk aphasia. What would be Bruce Willis's process coming through?
So Bruce Willis would call me and say, "Oh, Bruce Willis." That's the process. No, so he would basically talk to me for 15 minutes to 30 minutes on Zoom so I could decide if it's a good fit and if I think I could help him and he's appropriate to be in a program like this. And then if he thinks that if it looks good, then he would set up an evaluation and he would meet with one of the staff who would take a very thorough history, and then we would collect all his medical records. We'd send him testing to do, online computerized testing. We'd get depending what's been done, get some other testing, and then we would meet for an hour on Zoom or in person, and I would see where the holes are in the testing and, just confirm some things and then finalize the testing. And then about 4 weeks later, we'd meet in person where I could do a physical exam, review all the data that we've gotten back and say, okay, here's what's going on and here's the plan. And then we would make a written plan. It's usually a 15, 20-page document. And then we implement the plan, which means my meeting with them, it could be once a month or every 3 weeks or whatever. And then if we're doing the laser, then that means he's coming in here 2 times a week or 3 times a week. If we're doing neurofeedback, then that he can do that at home, remotely, and hyperbaric oxygen or ketamine assisted therapy. He can get his own HBOT, soft HBOT, and ketamine assisted therapy we do in the office the first time. But then assuming it looks good for him, we can do it actually from his home. So most of what we can actually do remotely, but the laser, we've got to have you here. Right now, we have a place in Maryland That's where I practiced for 40 years. So we can do the laser there, but we also do it here in New Jersey. And within the next year or so, we'll be doing it only in New Jersey, I think.
Where do you see the field going? We'll close out on this, Doc. Like you brought up AI. I bite my tongue because I don't want Jay to yell at me, but where do you see it coming in to help move the field forward, to raise the level of queries, to better the mental health for all? Where do you see in the future?
I think if they do a good job with it, that it's going to be very helpful. I mean, I have patients already who, when they're having a rough time, they go to Chat GPT and they say, "I'm having a problem. What should I do?" And it gives them a very good response, and they feel better. So, but it's only as good as the input, right? And so I don't know how good it'll be about creativity. I don't know, for example, if the AI had, let's say it had all the information I had in 2015, would it have made the leap that I was blessed with about QEEGs and laser and photobiomodulation? That, oh my God, this is a whole new way I could approach the brain and brain problem. I don't know if it would make a leap like that. That could be a human thing.
I piss off all the psychologists when I bring this forward. What if you just spend 2 weeks with ChatGPT and they just go through every single scenario to see how you answer it, and then here's your Dr. Hedaya?
It could be. It could be. I think it's highly likely.
Well, it's your knowledge. It's proprietary, right? I mean, you have it. I mean, it's your brand, and it can only get you so far. But my sister's a neuropsychologist too, and she just beats my ass when I say that. So, all right, Dr. Hedaya, what is your URL? Where can we send people your way?
So it's easy. It's like Whole Foods, WHOLE, only it's Whole Psychiatry. And I had it before they did.
Or Amazon.
Yeah, so that's what it is, wholepsychiatry.com. There's a lot of resources, by the way. There's a lot of videos. There's just a lot of, we've been developing this since like 96, I think we started developing. And we're, keep remaking the website, putting new information on. So try to make it a resource that people can really benefit from.
We'll have everything in the show details. Dr. Hedaya, Jay Gunkelman, thank you for another fine episode of the NeuroNoodle Neurofeedback podcast.
This is
It's been fun. It's been a wonderful meeting you, kind of facial image to facial image, I guess. 2D looks fine, So,
I need to grow one.
And like you, when you retired, it was too interesting, too much fun to avoid. I retired when I was 70, and I'm 75 now, and I'm as busy as I allow.
Listen, Jay, really a pleasure speaking with you and getting to meet you and talk to you. It's really a treat for me. It's really wonderful. Thank you so much.
Doctor, can we invite you back sometime in the future?
Anytime. It's my pleasure. I love your format. I do love your guitars.
I wish the people liked it when I played it.
I'm sure you're pretty good.
They have
worth the cover charge at a free show.
They have a fabulous band that's a tribute band to Blondie, and he plays the bass, obviously. And actually, she looks a bit Blondie-ish. The lead singer, the keyboard, and the lead guitar is absolutely a fabulous guitarist. Not to denigrate your skills, Pete, but
I know what my skills are, Jay. Don't worry.
She really rips that up. Anyway, they're a fabulously great tribute band, and if you ever have a chance to catch them, even if it's not primarily your style, they do a really good job.
Doc, I'm going to hook you up with my sister. She's the rhythm guitarist. She's a neuropsychologist too. You guys can compare notes.
That'd be great. Listen, anybody who wants to, I've recorded some songs, never sold one, but anyone who wants one of my songs, just shoot me an email. I'll be happy to.
Well, you know what? Send me one. I'll put it at the intro of the show.
Oh, it's a long one.
It's a short edit. Gentlemen, have a great weekend. Thank you so much.
Bye-bye.
Pleasure.
All right, bye-bye.
Take care.
The NeuroNoodle podcast is supported by listeners and businesses just like you.